So welcome everybody to our third Friday Flaum Eye Institute Visiting Professor Series. It's our pleasure to welcome Dr. Meghan Collins here from the Wilmer Eye Institute. We'll be giving a formal introduction of her following the resident presentations. Here I'm going to leave the disclosures up for you guys to read for our presenters today. Today we actually have three presenters, Rajiv, Matt, and Meghan. So here are Rajiv's and Matt's disclosures and learning objectives. And Meghan's disclosures and learning objectives. Just a reminder, the University of Rochester School of Medicine and Dentistry is accredited by the Accreditation Council for Continuing Medical Education. Again, you can claim up to 3.0 AMA PRA Category 1 credits, but please claim only the credit commensurate with your participation in the activity today. Here are the disclosures. And we'll be starting off our research spotlight with the work of our Director of Population Health, Dr. Rajiv Ramchandran. Then we'll have a short update on the school outreach by Matt Geringer, followed by three resident presentations, a short break to rest us up for the lecture we've all been waiting for by our visiting professor. So it's my pleasure to introduce Dr. Rajiv Ramchandran here today. This is going to help. Rajiv is an associate professor of ophthalmology at the Flaum Eye Institute, where he's part of the vitreoretinal service, an integral part of the vitreoretinal service. Steve, you missed that word. He's also the director of our population health effort, where he directs a team of staff, volunteers, and clinical collaborators to improve eye care throughout upstate New York. This work spans a wide range of issues and is highlighted by in-person and remote diabetic eye care and children's eye health. His efforts have been grant funded on the regional level and by the National Institutes of Health. And his research has been reported in numerous peer-reviewed publications. He's developing a growing reputation as an expert in population eye health. Rajiv studied medicine at the University of Rochester and then completed his ophthalmology residency at Duke. He then returned to Rochester to complete his vitreoretinal fellowship at the Flaum Eye Institute and subsequently joined our faculty. As a member of the Eye Institute, he went on to complete his MBA at the Simon School, and he's a member of the AAO, ARVO, the American Society of Retinal Specialists, American Telemedicine Association. I think there's a few more here that they didn't list. He also served in various leadership roles at Prevent Blindness and is executive committee chair of Vision 2020 USA. Please welcome Rajiv as he presents our population health update.
All right. Well, thank you, Dave, for that wonderful introduction. And thank you all for being here on Good Friday. So it's very Good Friday because we have Dr. Collins here all the way from Baltimore who's spending your time with us, and all of you here spending your time with us today. So population health at the URMC. I first need to thank all the great people here in this room, as well as Sherry Ann Bueller, there you are, and Talia Geringer, for all their great help, and all of my colleagues for really making this happen, and my chairman, of course, for giving all the support to make all this possible. So thank you all for doing this for our community. So population health and why it's important. Oh, I have to share screen first. I'm sorry. All right. So eye health is important in public health. Over 40 million people have vision-threatening eye problems in the United States, 4 million with poor vision, costing us $130 billion annually in the United States alone. This is just the US. We have a prolonged latent state for disease, which is reliably able to be detected, and there are strategies for these detections and treatments early on to prevent blindness. And then across the lifespan, you have from retinopathy prematurity all the way to age-related macular degeneration, very specific diseases that have different stages that can be looked at and identified. And of course, refractive error is a common theme throughout the whole age span here. And that's what we also are working on. Screening must be cost-effective and must reach the population with minimum inconvenience, which we all know that eye care also does. So why isn't population health and eye care really a thing of that everybody's practicing? Well, they did a report on this in 2016. The National Academy of Medicine, as well as the NEI and CDC and Prevent Blindness, all these folks got together and helped to support this. And they found that there were some areas of lacking. First, the Health and Human Services don't really have a program. There's no national agenda for eye health in the United States. And that's very interesting because a lot of countries around the world have this. And the WHO even now has vision and eye health as part of their initiative. But the United States, we really don't talk about this because we think, glasses, which is the most common disability. Look how many people here wear contacts and or glasses, right? And most common disability is not really addressed in our healthcare spectrum. The CDC wanted the CDC to develop a coordinated health surveillance system. Well, who knows now with the CDC funding what will happen with that? But for vision and eye care, it just reaches across all spectrums of the population, no matter what background you are, no matter what your race, ethnicity, orientation is. You all will be subjected to eye issues. Common set of standard clinical practice guidelines is also needed, so the providers need to get together and decide on how do we effectively do this, and people like Dr. Collins and others in the country are really working on this. One thing that we're really focused on is increasing access to eye care, including traditionally the non-eye care settings, and also increasing workforce training. All these students here, the Mobilize group, you guys are part of it. We may not all go into ophthalmology, but you will go into your specialties with a better understanding of what it means to check a vision, check an eye pressure, and to be really more oriented about eye health in general. Community and state needs assessments needs to be there. Eye health is not really a part of that. Nobody really talks about vision doesn't kill you, and in these eye diseases really, unless retinoblastoma maybe, but otherwise, you don't really die from it. So this is the reason why eye care kind of gets left out. And then developing these community networks and collaborations that we're doing here with the schools and with our community partners, that's really important to make all the difference. So this is our Western New York population where we have our Flaum eye centers. We're doing the surveillance risk stratification to really implement prevention strategies that preserve sight and triage people to appropriate level of care to improve sight at a lower cost to society. And this is what we're doing, and we're really focused on these areas: refractive error and children's eye diseases that Dr. Geringer really has helped to spearhead. Diabetic retinopathy, which is my passion, glaucoma with Dr. Karen Allison really working on that, and cataract and age-related macular degeneration, rounding out the diseases that we really look at. So our mission is to reach people within and beyond traditional eye care settings in a systematic, data-driven way to really prevent eye disease and vision loss and blindness. The goal is to reduce the percentage of people that have ocular disease and need further tertiary eye care. We do this by engaging the community, like I said, expanding our clinical access to care by getting out into the community and getting to people before they become patients, emphasis on comprehensive eye care, and looking at some of our IT and informatics that we're looking at to see how we can better surveil the population and conduct this populations-based health outcomes research and implementation science-focused work. So diabetes, is my passion, being a retina specialist and seeing people in my chair all the time with traction retinal detachments and blinding diseases, and a lot of times I couldn't do anything for them. So how do we get and tackle this? Well, we go to the source. We go and find people before they get retinopathy, before they get a vision-threatening disease, and try to triage them. So we have, of course, these cameras. It's done in a lot of places, set it up in 8 clinics around the city of Rochester and also in some rural areas as well. to try to increase screening for diabetic retinopathy in safety net clinics. This is the only metric that's tracked nationally that has relevance to eye care, because all folks with diabetes need an annual eye exam at least, but now it's every 2 years according to the HEDIS metric. And there are about 7,000 patients in our URMC system, most in safety net clinics, that are not getting their annual eye exam out of the 20,000 patients that have diabetes. So our results are really from 2018 and 8 clinics. We've increased the percentage of screening to about 57% from 43%. When we started, we've screened over 2,700 patients now out of a total catchment of 3,000 patients who come to the clinic. So 50% of these patients needing eye exam are not even coming to their primary care doctors. So maybe there's another approach we need to take to get to these people. And of that, 57% of those 2,700 patients screened have completed their eye appointment, have completed their, 54% have scheduled an eye appointment, and 57% of those have completed an eye appointment. So each level we go, we get an attrition of people over time, which is a common theme you'll see in some of the things that we're doing. And 11% of those have had vision-threatening conditions, and a good sense of almost 60% of those have actually followed up at Flaum for getting treatment. So these are the outcomes that we really need to track going forward to make a difference. And we're using implementation science to understand the various settings of this, right? If you just put in a camera, it's not going to automatically get used and everything gets better. Same thing if you tell people to take their glaucoma drops, they're not automatically going to take glaucoma drops and get saved for glaucoma. If you give a child a pair of glasses, it's not automatically going to wear glasses and see better and function better, right? So all these things need some coaxing and care. So looking at the outer settings, outside in the community, the inner settings, in this case, it's the clinic settings, patients that we treat in our clinics and in the primary care clinics, the staff we work with, our non-eye care staff, how do we orient and work with them? How do we find champions? What do we do about technologies and clinical workflows? How do we integrate that, make it better? Our EMR system, all those things need to come together. It's a very complex system in clinics and also in the community that we serve. So we also have this vision van. So this vision van is the other component of our care in addition to telemedicine. And it's really helpful for us to do pop-up clinics. We deliver the equipment to various settings, and we provide the care that we need to give. So we've done a lot of community outreach activities. So these have been done in places of worship and community centers. And we do pediatric vision screening with these criteria of distance, near, and vision, color vision, and adult vision screening, where we also use a fundus camera to do the screening. We also use the fundus camera on kids too, when their ability to do that exists. We've done 31 events 2023 and a little bit less over time because we're trying to refine our focus on some of the key areas we can capture more people. And we're trying to refine this process over time. So not just willy-nilly helping everywhere we can, but always having a targeted and focused approach so that we can get those people we screen to further care. We work with community navigators to get people insurance. Luckily, our community has 97% of the population insured, so thankfully that's there. But we need to get them a right insurance because all insurances don't cover the vision care that they need, especially glasses, and that's a big thing for our population. We also do this vision outreach in senior centers. We do this at St. John's Home today. Sherry-Ann was busy there with Dr. De Silva, helping people at St. John's at least once a month. We've have done 44 patients out of 49 patients in 2004 and expanding this in 2005 now into 2006. Our other approach is the rural care. So these vans go out to our primary care clinic. That's part of the URMC in Williamson, which is in Wayne County, east of here. And we've done 50 patient exams in a pilot over the last couple of years, and 10% retinopathy rate because we focus on folks with diabetes, and 50 other diagnoses were found. So it's not just retinopathy, you're finding retinal tears, you're finding glaucoma, cataract, other things in this population. But why we're here is we're focusing on our pediatric mobilized program. So this is Tom Scalzo, or optician, retired optician, who came back to help us out. And he's been busy giving glasses to your kids and been very, very active in promoting this on the optical side. So we screen according to the New York State mandate. New York State has a mandate from pre-K, K, and every odd year to screen for vision, which is very thankful. A lot of states don't. There are 40 states that have some type of policy, all varied. and it's a very confusing thing. But we're trying to overcome these financial barriers that exist, and transportation barriers and other educational and health awareness barriers to really push this forward. So through this program, we have screened many kids, and I don't want to get into the weeds of the numbers, but I just give this overview here, and our residents are going to present more on the numbers in a little bit. But we've done 6 schools in 2022, 2023 after COVID. 2023 to 24 went to 8. 5 of them had exams because the Rochester City School District didn't renew their contract with us yet. They were still working on it. And then 2024, we've gone to 14 schools, 9 for exams. And this is overall over two-fold increase from 2023, over 2 years. So we're moving up. We're moving the right direction. Eligible students have increased up to 4,000 kids. The screening total screen is 3,500 of those students. So we've really almost captured that over 80% mark, which is what our goal is. Again, over 2.5% increase. Those needing eye exams have also increased in this population that we're screening. So we're capturing more and more kids who actually fail their vision screening and need more care, over two-fold. Consent, that's where the numbers drop a little bit, right? So we only have 1.5 times increase in consent. So how do we get the permission from these kids, or the parents, to actually do the exams? And that's a key thing. But our rate of exams are pretty good. So we were only 50% last year, rate exams, but now we're more than 50% this year. So again, it's increasing over time. And the glasses given, if you look at the number of examined and glasses given, that ratio has gotten much more closer to 100% there, because that's a key thing. We don't want to get so many people who are false positives. We want to keep sure that we keep screening and examining those people who actually need care and need glasses. And we found that a lot of people do need further referral to Flaum for regular care more frequently than annually. And so this is a key thing, that we're finding other diseases just besides refractive error, and we're really making a big impact in the community. So with that, we also did rural community screening at the Lions. So Dr. Geringer went out and did eye exams for 17 individuals that Saturday during the day. And the Lions is a good trip. It's an hour at least out here, and gave 10 glasses. We didn't have the RCSD contract that year. This year we have 2 schools left to examine, so our numbers may go up a little bit. Again, no RCSD contract, but thankfully, with the hard work of Talia and Sherry Ann, 5-year contract to provide vision screenings and eye exams have been approved for RCSD. So next year we're going to be even busier, because our schools will increase and our number of outreach will increase as well. So I thank you for all your support, and I do want to cede a little bit of my time to thank our optometry group and our optometry residents. So I invite both Emily Zimmerman and Hero Patel to come down and to give a little presentation to Dr. Collins here really quick, to come on down. So Emily and Hero are our optometry residents, and they've been very active in learning all about eye care and seeing how we integrate in the community more. And thanks to Dr. De Silva and Dr. Donaher for really spearheading this. I'll cede the floor to you guys. There you go.
It's already sharing and everything? Yep. Okay. Thanks for the introduction. Today, Hero and I are just going to be very briefly discussing an optometric-centered case of a 14-year-old Hispanic male that presented to the Flaum Eye Institute. This patient was in the behavioral health unit long-term for 5 months before they actually presented for a refraction exam. And the patient was complaining that it was difficult to see far away with his glasses and without his glasses. He did previously wear glasses full time, but unfortunately his glasses have been broken for 4 months. So this was only 1 month into him being inpatient at the hospital. And unfortunately it took quite some time for them to send him for an eye exam. And his ocular history was just remarkable for the refractive error. And then medical history, he had an extensive medical history for some behavioral conditions that are all listed up on the screen there.
So for his exam findings, the entrance testing was normal. His visual acuities with his current correction, which he brought in, they were pretty broken. There was one temple was missing. They were pretty beat up as well. But with that, it was 20/70 in both eyes. And the lensometry was -3 in the right eye and -275 +50 axis 46 in the left eye. So after refraction, there wasn't really a big change, but in phoropter, with that change in refraction, his vision improved significantly. If that tells you anything about the condition of the glasses, they were pretty scratched up. The rest of his clinical exam ended up being normal. So the management, we gave him a new pair of glasses. We gave him a new glasses prescription, and we have the FEI optical here in the building with us, so he was able to go downstairs and order some new glasses.
So as a lot of us know, the prevalence of myopia has been increasing drastically. From 1990 to 2023, it's been known to increase from 24% to 36%, and these numbers are projected to increase even further to about 40 to 50% by 2050. So a lot of things are being researched to try to prevent this myopia progression, biggest ones being contact lenses or the atropine eye drops. But also it's been studied and proven that just spending 2 hours a day outside can prevent the progression of myopia. So I think this is something that we should be considering in patients that are myopic and spending long periods of time in the hospital.
So now we have some questions for our guest speaker. First, do you have any hospital policies that ensure patients staying at the hospital for long periods of time are able to get routine care? How do we, as a department, advocate for these patients to ensure that they are getting the eye care that they need? And should long-term inpatient children have vision screenings, given that often they can't express that they have blurry vision or symptoms of amblyopia?
Already. Well, wonderful presentation, and I love that you recognize, inpatients, which I think are largely sort of ignored when it comes to preventative medicine and preventative eye care. I don't know if we have any specific Hopkins hospital policies on this per se about kids that are in for a long time. We do have kids that follow with us and come in and out of the hospital, particularly our oncology patients. And so if they happen to be in the hospital when they're scheduled for an eye exam, we usually bring them over. So I would say the cases that it happens with the most frequency is the ones that are already scheduled, or parents are, remind the doctors, oh, they were supposed to come for an appointment. The other one, interestingly, to probably the retina team here, is it's the ROP ones that kind of bounce in and out. They're home, they're out of the hospital. We are pretty cautious in making sure they're not lost to the follow-up. I think it would be great to think about advocating for those patients who are in hospital long-term, particularly the ones in the amblyogenic age range. You'd be surprised at the number of babies that we see who, are in for, maybe they had a facial burn and they have a swollen eyelid for like a month or two, and that could be amblyogenic in that age range. I think there's probably got to be, better education between the ophthalmology and optometry services and the hospital, that if you have a patient that meets any of these criteria, please consult us. I think I probably will not make myself popular with residents to suggest more consults. I know I wouldn't make myself popular with my residents. Long-term patients having vision screenings, it really would sort of depend on the parameters of why they're long-term in the hospital and whether or not they would need vision screenings. But I think you're absolutely right. 75% of kids less than the age 13 are known to be asymptomatic for any vision problems. So they're certainly not in a setting that, in a classroom, teachers will notice behavior. They're rubbing their eyes, they're not paying attention. They wouldn't necessarily notice that in the eye setting. So it's a nice idea to think about for sure.
Thank you.
Thank you.
Thank you.
Thank you, guys. That was great. Next up, we will start our resident presentations. And with that, I will introduce our Master of Ceremonies for our next round here is Dr. Matthew Geringer. So Dr. Geringer is one of the foundational pillars of FEI. He started his career here after completing a pediatric ophthalm fellowship at Duke. Go Duke. Since then, he has rose from the rank of assistant professor to full professor in just a short time. Along the way, he started the FEI Pediatric Ophthalmology Service, served as the residency director, and conducted clinical research through PEDIG. resulting in multiple publications. He continues to do research and has become a nationally recognized expert in ophthalmic education, presents his work on resident and fellow training at AO meetings and others. Besides being one of the most trusted and sought-out pediatric ophthalmologists in our region and in the country, Matt is deeply committed to our outreach program to school children and has dedicated numerous hours to making this happen. It's a family effort on his part. He serves on the FEI's medical director of our mobilized pediatric outreach, providing screening for rural and urban and suburban schools. So Matt trained in medicine at the University of Michigan, did his residency at University of Pittsburgh before his fellowship at Duke. So please give him a warm round of applause for his presentation, School Outreach, Giving Students the Vision to Succeed. Share your screen. There you go.
Thanks, Rajiv. Pillar, that sounds kind of old, I think is what that means. So I'm just gonna give kind of a 5-minute start to our residents. Typically we'll present patients, residents, we're gonna present populations today because I think that's probably more appropriate for our discussion. I've got no financial disclosures. We all know that kids that don't do well at school, and that can be a problem. Some kids will be labeled as bad students or misbehaving students because they just can't see the board. So we come out and do screening for the kids to get them glasses so they can perform better at school. I like to kind of frame this through the lens of justice. So in my mind, justice means that we should treat similar things similarly, unless there's a good reason to treat them differently. And I'll posit that economically disadvantaged families have more barriers to attend appointments in our offices. When I first got into practice, I thought I was proud of myself. I saw all the Medicaid kids, I saw all the uninsured kids, the free kids, but that's leaving out a big chunk of patients. So we now go to the schools. There was a famous bank robber said, why do you rob banks? Because that's where the money is. Why do you go to the schools? Because that's where the kids are. So going out to the kids at the schools is how I spend my Mondays and Fridays now, and I love it. So kind of our goal is to make sure no child is held back academically or socially because of vision problems. And we partner with the school nurses at rural and urban schools and some community schools. And then we perform in-school exams for students who fail the screening. We deliver glasses on site. You saw pictures of Tom. Tom loves driving up with his Corvette with the top down to go to these schools. And then if the kid needs to follow up in the office, the social worker can follow up with them if needed. This allows the families not to have to take time off of work, don't have to find a car or a bus or a taxi to get them to the office. So we do all on site for them. Scope of project. So we try to figure out what's the best way to use our resources. If you look at a metric called economically disadvantaged students, which is kids that have free lunch, SSI, food stamps, New York State averages about 58% for school districts. Monroe's average about 53%. But if you look within the surrounding counties, all pretty similarly here, where we've had our brick and mortar offices is in Monroe, Geneseo, Livingston, Ontario, is where we have pediatric practices. So we cover a lot of the community here. If you look at within Monroe County school districts, there's a huge range. So Pittsford, which is one of our more affluent areas, has about 3% of kids that are disadvantaged. You can walk 5 minutes and get to City School District, which is 91% of disadvantaged kids. That's kind of the sharp sharp difference in affluence in our communities. So we've targeted, here's where our offices are. Prior to 3 years ago, we did not have a city school district office. We had Webster, Brighton, and Pittsburgh, more affluent places where we're seeing patients. Luckily with Dave and Christine getting our South Clinton office and our Jordan Health's office, we have a presence in the city as well. So here's some of the sites we go to and kind of their level of economic disadvantaged kids. Rochester Prep is a charter school. 94% of kids in this school system are economically disadvantaged. There's one of our campuses there has 15% of kids are unhoused. They're homeless kids going to school here. RCSC is very high, and then we have a number of other charter schools and community schools here as well. So we're currently partnering with somewhere between 16 and 26 schools, depending on how we're looking at things. Adding 3 to 5 schools per year is our goal. We've done about 8,000 screenings in these schools and about 500 in-school exams. program's grown over the past 3 years. Started with 6 way back when. We are up to 20 or 26 this year. So what do we find? Common things are common. Refractive error is very common. Probably 80% of the kids will need glasses that fail. But there's important things. There's amblyopia and strabismus, cataract glaucoma, neurological diseases, and tumors as well. Rajiv kind of went over this. This is Tom again, one of our famous pictures of Tom at the schools. So what is screening in schools? So we go out, I attend a lot of these. We have a great group of helpers. And we have usually between 3 and 5 screening lanes where we do all these. We screen kids in pre-K and K, 1st, 3rd, 5th, 7th, 11th, and do distance, which is probably important. Near and color, probably not as important. And we have a group of college and medical students, residents and fellows, staff, faculty, and then community members. And the great thing about this is the people that come out love it. I mean, Sherry Ann makes this fun for everybody. We've got, people that do the phones in the business office come in, volunteers from the community that all really enjoy the time there. I think it's like reliving our childhood again, being in the schools with the small chairs and things. One thing that we've learned, and I think this is working for us, is something that I kind of consider augmented screening. We'll do a recognition acuity with either Snellen cards or Allen cards. If they fail, we'll then bounce them over to the instrument screen. So we've got spot screening that we bring out with us. If they fail that, then they failed. That's a true fail. If they pass it, then we'll recheck their acuity with a more experienced screener, one of our techs or me. If they fail that, they've really failed. But a lot of those will pass the second recognition screening, so they're kind of false positives that don't get into the exam bucket. Here's Matt Haney at a school. So the kids that fail, we ask the parents for consent to do in-school exams, and that's been a hiccup, and I think I've learned some things from Meghan so far today that might make that process easier. We're about 30 to 40% of most schools with kids that fail have the parents send that form back for us. The kids that get glasses from Tom. And if they need a follow-up, we have now 2 convenient offices for the kids to get to downtown. That's kind of an overview. We're going to have, who's up first? Kayla, are you doing introductions? Dave is going to do introductions. So thanks and enjoy the experience that we have here.
All right. So now we'll start our resident presentations with Dr. Kayla Ozimba. She's in her 2nd year of residency at Flaum, and she comes from Rochester, from Phoenix City, Alabama. She studied chemical engineering at Howard University, where she graduated magna cum laude, then attended medical school at the University of Alabama. Kayla says that she really enjoys the supportive environment from the faculty, co-residents, and staff at FEI, and that one of her reasons for choosing FEI is the alignment with community health, and has already been very involved in FEI's outreach work, including school vision screenings and health equity. She also has been a big supporter of FEI's efforts to develop the careers of minorities who are underrepresented in medicine and ophthalmology. Welcome, Kayla.
All right. I'm Kayla. As Dr. DeLauro mentioned, I am very passionate about community work, and it is a big part of why I chose this program. I think what the population health team, people like Dr. Geringer, do is just amazing. And so I have been tasked to talk about some of our rural school screenings or vision screenings in communities around upstate New York. And so here's just a map of upstate New York. We're up here in Rochester. And so per the census, there's about 43,000 square miles of rural land in upstate New York. And about 17% of the New York State population lives in rural areas. And so most of these areas are kind of determined to be health underserved areas, especially for primary care and for subspecialty care, which is even worse. And so Flaum now has, like Dr. Geringer mentioned earlier, we have these offices that are kind of creeping down, headed towards the southern tier and towards Buffalo and Geneva, Geneseo and Batavia. that and hopes to bring care to our rural populations. So that's where the gray stars are. And then we are also doing vision screenings in areas like Lyons, Palmyra, and Albion. And so these 3 locations are the locations that I'll be highlighting today. So Lyons is a small town. It's kind of highlighted here on this map. It's in the south central part of Wayne County, which is a neighboring county. It's located on the Erie Canal, and it's the county seat of Wayne County. Per the 2021 census, there's about 715 children that live there, ages 0 to 17, mostly Caucasian, 83%, 10% African American, and 7% Hispanic. This is the Child Opportunity Index, and so this is just a tool that combines 44 different factors and determines, like, do children in this neighborhood or in this area have the tools to succeed, whether that's on education, health, and social and economic domain. And so we can see here that Lyons is determined to have a low Child Opportunity Index. So these students were already screened at their schools, and Dr. Gieringer and went and evaluated them and examined them at Lyons Community Center. So we had 17 students in total. 10 of them, so 59%, required glasses, and 2 of them, 11%, required follow-up in less than a year. And so you can see here that these numbers are spread across all different age groups and grade levels. And then here also, looking at the younger kids, needing glasses. So half of our pre-K and kindergartens and all of our first graders. And then even going on to the older kids, these are kids in 4th grade, 6th grade, that are still, our vision screening is still able to impact and give them glasses prescriptions. Next area is Palmyra and Macedon. So these are 2 areas here highlighted on the map. Child Opportunity Index and levels are a little higher here. So they're about moderate, educational domain and low to moderate. And then health and environmental domain is actually rated to be high, and socioeconomic is high. So these towns are located in the Finger Lakes region, along the Erie Canal as well. There are about a little more than 1,700 children that live here, ages 0 to 17 per the census. And then 83% Caucasian, 17% Hispanic. And there's about a little over 1,600 students enrolled in the school district. We were able to screen up to 320 students, but we were only able to screen 297. So we screened 93% of students across pre-K to 1st grade. And 47 of those, which is 16%, felt their vision screening. And then our last area is Albion. This is the area that's, it's about 30 miles west of Rochester between Buffalo. It's also located on the Erie Canal, but to the west. The Opportunity Index, Child Opportunity Index here is a little moderate. Our demographics are 98% Caucasian, 1% African American, and 1% Hispanic. There's about a little over 1,600 students in this school district. And we screened almost all age groups. So like Dr. Gieringer mentioned, New York State recommends that pre-K, kindergarten, and then every odd grade should be screened. And so we were able to do that out in Albion. So we screened 688 out of 884 children. That's a really good number, but the percentage-wise, only 78% of the students were in school those days. The other students were absent. So out of our screening days, we did miss a good portion of the population in the school. 140 of those children then failed their vision screening, which is 20%, but only 27 actually brought back complete packets for examination. So the packets are a really big barrier, and we'll see in some of the subsequent slides, actually even a small percentage of these aren't technically the students that we screened. Some of those were students that have failed vision screenings in previous years and then defaulted to a repeat examination. And then 20 out of the 27 students that we were able to examine required glasses. So about 74% of the students that were able to see a physician required glasses. 19 of those required close follow-up. And so this is just looking at that school across the grade levels. So we evaluated 123 students and 15, I'm sorry, there were 123 students. We were only able to screen 15 of them, and 2 of them failed their vision screening. On to first grade, out of 120 students, we screened 77. 13 of them failed their vision screening. And so 143 for the third graders. We screened a really good portion of the third graders and the fifth graders. But you see here kind of like the kindergartners and the early age groups can sometimes be weren't present or in school the days that we did the screenings. So now looking at talking about the consents and how getting the parents permission to examine the kids is a huge problem. So in first grade, as you remember, 13 failed their vision screening, but none of them brought back their packets to be seen. And then here's where like 2 patients in second grade were evaluated, but those weren't necessarily screened. Those were patients that had failed vision screenings previously, and parents signed a packet to send them. But if you look across this, you know, sometimes when we've had our population discussions in our journal clubs, we're often like, oh, they're kids, you know, how would you expect them to take packets? But I mean, if you follow this up to 11th grade, the students are still not bringing back the packets. So it's not necessarily just because they're young elementary schoolers. There is an issue with getting the information to the parents and the information getting back from the parents to the child to the school.
Yeah, so this was there present. Albion actually did their own screening. Sorry, Albion actually did their own screening. So these are kids that were screened by the school, and then they kind of reached out for the consent forms. Yeah. Yeah, we didn't have it as much, yeah, at the school. Yeah. Yeah. Yeah.
And so for my my key takeaway, I think like looking at this data is just finding a way. I think that's why like health literacy and health education is so important to making sure that parents know what we're doing in the school systems. And so this chart just kind of shows that. We started out in Albion, we started out with 884 students. We only screened 688 of those. 140 failed their vision screening, but then going down to the consents, you know, we lost out of 140 students that failed their vision screening. We only really got 18 of those consents returned and 15 complete packets. So huge point. And we can see out of the 15 complete packets, 13 of those children required glasses or needed glasses. So how many of that 140 that we didn't see could benefit from glasses, which I think is big. So some of my questions are, what roles do schools and community organizations play in vision screenings? And how can ophthalmologists collaborate them? How can technology such as mobile screening units or telemedicine be leveraged to improve access to vision care in underserved communities? And if spectacles are donated by philanthropy, is your prescribing threshold different than if the family pays for them?
Great job, Kayla. I also appreciate, I'm from Connecticut, but I know nothing about New York geography, which is a little bit embarrassing. So I feel like I'm learning a lot about upstate New York geography from your slides too, which was really interesting to see. So I agree with all your takeaways, but I feel like there's a couple others too. One, you're just demonstrating this is really hard to do. It's so important and it's so impactful, but it's really hard to do. And I think you're going through the growing pains as you start to build these programs, all of the challenges, which are exactly all the same challenges that we faced in Baltimore and other cities that we work in. And it's why it's so important to sort of build these systems and scale them up over time. Regarding, I'll start at the bottom question and move up. Our prescribing guidelines are the same. And the program that we have, I mean, kids have insurance, they don't have insurance, they're documented, they're undocumented. We don't check any of that. Doesn't matter. They will get an exam if they need an exam. If they need glasses, they'll get glasses. And I think we feel really importantly about that. Technology is really an interesting question here. And Dr. Geringer, when he was going through your vision screening process, what we found, we're doing an NEI study on this right now, looking at traditional methods of visual acuity testing like distance acuity, near acuity, color vision, and instrument based. So spot and plus optics. And you guys can probably guess for like a 6-year-old kid to do distance visual acuity takes a couple minutes. And it's a, you know, a testament in patience to like, go on, keep going, try the next letter, versus a spot literally takes like 15 seconds. So one of the interesting things about thinking about technology and screening is, should we be moving in the direction of using more instrument-based technology for screening? And I will say, in the ophthalmology and optometry community, I think the jury is out on that. I think there is not conclusive data in the school age population that instrument-based technology can replace it. But in practice, we're seeing it a lot. Telemedicine is a really other kind of captivating idea. And Children's Hospital LA has a project going on using telemedicine. They have kids come in, they do the screening. If they fail the screening, they have the mobile vision clinic come and do the school-based eye exam. They say they think they have strabismus. They actually have a telemedicine option that at the end of the day, the child can come back, the parent can come back with them, and they do a telemedicine appointment with a Children's Hospital LA pediatric ophthalmologist. So it really helps with that final place where you get a ton of attrition, which is they have an exam at school, maybe they need glasses, but maybe they need something else, and how do we get them into the community? And in the first question, I think this is sort of, for me, like a constant challenge in pediatric ophthalmology. I'm on the APOS Vision Screening Committee, and we had a workshop on vision screening at APOS this year. And it's at the same time as a strabismus workshop. And how many people do you think came to the vision screening workshop versus the strabismus workshop? It's hard sometimes because we don't always get as excited about public health as I think some of the people in this room are. And I think it's really important that we do, just from thinking about population health, but also thinking about advocacy and advocating for policy changes at the state and national level, like a population eye health agenda for kids. What should we be doing? So I think it's really important for us to play an important role with schools, community organizations, Lions clubs, because there's Prevent Blindness. There's a lot of people in this space that have a wealth of knowledge, but also would benefit from the perspective I think we can provide.
Yeah, I have a little remark on the mobile screening or the portable devices to measure refraction. I don't know if you guys are familiar with a technique with an instrument called QuickSee. So that is, I think, pretty well proven as, you know, way better than retinoscopy, and unlike other autorefractometers, because it's kind of a see-through, it's not affected by instrumental myopia or accommodation. So I just was wondering if you're using that, because that could really replace measuring acuities and doing a really fast refraction, but getting the refraction that produces the best far vision.
Yeah, this is growing in kind of interest and popularity so much, but we don't use the QuickSee in our program. We use Spot as part of our program. So there's autorefractors and there's photo screeners. But the NEI study we're doing right now, we're actually comparing autorefractors to photo screeners to traditional acuity in the school age population. Because historically, most of the studies done on the devices was in the pre-literate age range. Because the idea was you have all of these kids that have amblyopia risk factors and we have no good way to test their vision. But I would say over the next couple of years, I think we're going to see huge shifts in the field as more data comes out. And again, just from kind of a big turning point was the pandemic. Just from infection control standpoint, a lot of even APOS had a policy change that they said you can use instrument-based screening for vision screenings, which they historically had never said in the school age population.
All right, well, thank you.
All right, next up is our resident Brittany Wong. She's a native of Fairfield, California, and earned degrees in neuroscience and French from Duke University before a year as a Fulbright Research Fellow. She received her medical degree at UCLA, where she was a Gold Humanism Honor Society recipient. She's co-authored various publications, including Pediatric Retinal Imaging, Gene Therapy for AMD, Stereo Acuity Testing, and Corneal Transplantation. She enjoys languages and most recently has been studying German, and she looks forward to learning about all areas of ophthalmology and is particularly excited to work with pediatric patients. B. Gates.
Okay, let's see. Go back to this and share it. Okay, thank you so much. I'm excited to discuss pediatric mobilized in urban settings now. Let's see. Okay, so I'll be chatting first about the Rochester City School District. So this is from the same collection of maps that Kayla presented. As we can see in this legend here, looking at the region of Rochester City School Districts, much of this area is categorized as the very low child opportunity level in this light green or light blue color. Centrally here, Rochester has some of the highest levels of child poverty in the whole nation. And so this is a particularly relevant demographic to focus on here. So for demographic information of the Rochester City School District children, an overall summary slide or graphic is on the left here, looking at the breakdown of the population of students here. Of note, there's a significant percentage of the population of these kids are English language learners. The number one language is Spanish, followed by Arabic. Similarly, a large percentage of students have disabilities and markedly high levels of economically disadvantaged, so at 90% in this group. So looking at the screening that Pediatric Mobilize has done in this population, first starting with the 2023 to 24, there were 3 schools within this school district that Pediatric Mobilize went to. And so in summary, a total of 834 kids are enrolled. 601 or 72% were screened. Of those failed screens, 30% had failed screens, and then of that, only 17% had completed consent. So similarly to the data that Kayla presented, this has really been a major barrier in terms of the kids who are able to be served by this program. Then looking at this ongoing school year, 2024-2025, 6 schools were participating in the screening process, and a significantly higher number of total kids in the enrollment, 1,290. Of these, a large percentage, 84%, were able to be screened, over 1,000 kids within the school district. And of those failed screens, about 29%. And those children, to my understanding from Dr. Geringer, that is an ongoing school year, so we don't have all of the data from the rest of that. The other urban school system that I was looking at was the Rochester Prep Charter Schools. As Dr. Geringer discussed, a really high percentage of these children are considered economically disadvantaged, 93%. Similar breakdown here of demographics in the figure. 2% are English language learners, and about 11% of these students have disabilities. Looking at the data from Pediatric Mobilize last year, a total at these 2 schools of 734 kids were eligible for screening. 626 were able to be screened, or almost 90%. About a third, or 26% of these kids failed their screenings. About a quarter of those kids had completed consents. So similarly, a large drop-off was at that branch point. Of these, 61% were able to have in-school exams, and a really high number, 80%, were able to get glasses prescribed. And of these kids, who about 14 needed in-office follow-up sooner than 1 year. And then looking at the Rochester Prep Charter Schools for this year, 788 kids in total were enrolled in these schools. And there were 3 schools involved. St. Andrews had 7 kids who were seen for follow-up. So it's been interesting to see the longitudinal care that's possible with this program. Almost 90% at 86%, or almost 700 of the kids were able to be screened from these children, and about a third of them failed screens. Similarly, this school year is ongoing. So in terms of the in-school exam data, that is still ongoing for some of these. So rather similarly to Kayla's breakdown, but I'm here talking about the urban population, the Rochester City School District has the highest percentage of economically disadvantaged and the second highest child poverty rate in the state of New York at 90% and then 44%. And as I mentioned, this is also one of the highest child poverty rates in the entire country. Within the Rochester Prep Charter School system, 93% of the children are economically disadvantaged. So this is a particularly important population that we're able to reach through the Pediatric Mobilize. Pediatric Mobilize has really high rates of screening amongst the total student enrollment in partnership with the schools. And similarly, of those children who have parental consents returned, really high rates of exams that are able to be performed and then subsequently glasses prescribed if needed. However, similarly to in the rural population overall, low parental response for these in-school exams continues to be a major limitation. So some discussion questions. What strategies have been effective in ensuring follow-up care after initial vision screening identifies a potential problem? And how do socioeconomic factors and health disparities impact pediatric vision care? What policies could help bridge these gaps? Big questions here. Are there any tips on increasing parental consent rates? That continues to be a major barrier in multiple settings for this program. And then what are the trade-offs between full exams with limited parental consent, as well as limited exams that, for example, wouldn't require dilation and could be done potentially without the same consent barrier? What are pros and cons? Open it up to the floor.
I realize I get so much homework today. Again, really interesting presentation. I'm kind of fascinated because this keeps happening when I hear presentations like this. The failure numbers are very similar to ours. The initial consent rate really similar to ours. The number of prescribed glasses. So it's just fascinating for me. You go to so many different communities across the country now, and the numbers keep having a lot of concordance. I'm going to save 1 or 2 for my talk, so I still have something to talk about. You guys have basically covered all of my slides already. I'm furiously taking notes. I'm going to talk a little bit about consent because I think this does seem to be an area that we have learned a ton in, and just a couple kind of considerations. So one, just to make sure everybody's familiar, opt-out consent is when you send something home, whether it is paper or another method, and they only need to give it back to you if they don't want to participate. Opt-in is where they have to respond in order for them to participate. So you have to get some type of acknowledgement, response, email, phone, or paper written. So what we do in Baltimore, our screenings, which are done by a health department screener, are opt-out. Letter goes home, says you're going to have a vision screening. If you don't want it, send us a letter in writing. And of course, just because of like principles of behavioral economics, people don't want to do extra stuff if they don't need to. So they don't, nobody's going to take the time to write a letter back to us. So everybody gets screened. We do what I think you're defining as limited eye exams, because our eye exams are not dilated, but we're still required to do full active opt-in consent. And I think the there are no standards on this. There are no sort of legal standards. There are district standards, and districts have really very strong different opinions on this. We've recently done a survey. It looked at how many programs in the country are using opt-in versus opt-out. Actually, opt-out has become the major the way to use to do consent. Most programs are actually doing opt-out, but Baltimore has made it really clear with us they do not want to do opt-out, so we do opt-in. So how do you make it better than the 25%, which is where we started? And it's taken us years to get where we are now. But we really sort of had to dig in with the school district as to why people were not consenting. So we did a bunch of focus groups and interviews, and sort of the main reasons were people just didn't even know about the program. So maybe something went home, but they didn't read it. They thought they were eligible or ineligible. They thought they were eligible because they had Medicaid, or they thought they were ineligible because they had Medicaid, or they thought they weren't ineligible because they didn't have insurance at all. So sometimes things like that, and they thought maybe there were out-of-pocket costs associated with it, which there are not for our program. They just mistrusted the program and did not want to have an exam done when they weren't present. Or they had an existing eye care provider. So those were sort of kind of our main categories of why people said they did not participate. By and large, the biggest being they didn't know about it and they didn't understand the costs. So we spent a lot of time sort of improving our communication on what the program was, what it wasn't, what the costs, or we don't have any out-of-pocket costs for people. So, and then we started partnering with the teachers and the schools. So we now have it's really complicated, and I have a slide in my talk that goes through it. We do universal consent at the beginning before we do vision screenings at school. We have a universal consent that goes home that says you'll have a vision screening. If you fail, you will have an eye exam. If you want to, return this form. And that sort of starts us along the way of getting some forms back. After the vision screening, we do targeted follow-up. So any kid who then failed the vision screening, we send that form home electronically again. So we start electronically with everything, with emails that we have from schools for parents. If we don't get that form back in a couple of days, we do a paper form. If we don't get that back in a couple of days, we do phone calls. So with all three now, we just presented on this at APOS. Our last year we were 86%. This year we're at 90%. So we're very high, but that is a resource intensive way to do it, but it works. But you sort of have to do repetition, and multimodal tends to have been our approach.
Comment?
Has someone looked into getting the consent, like at the moment that the child enrolls in school, in the school year, and then it's done, and I don't know.
No, it's great. So Fort Worth ISD, they do that because they have a program with Alcon that does at the beginning of the year. Chicago Public School Districts does the same thing. So there's a school health packet that goes home. So parents tend to appreciate getting all of the forms that need to be filled out for the school year at the beginning of the school year. We had historically sort of wanted to do that, and then with the pandemic and the fact that screenings happen at various times of the year, we shifted to do about a month before the screening so that they sort of remembered, it was fresher in their memory. But that certainly is an approach that was worked really effectively in a lot of places.
I was wondering along similar lines, if something like school required sports, that's something that looked into the basic component of school and higher completion.
Yeah, I think anything where you're stacking with something else that they already have to do. So we sort of use that concept of if they're coming to school for back to school night, report card pickup, we really always try to piggyback on something else that might be going on. So um, other forms that they have to bring back to school is one example. A lot of times we've also done incentives too, and the incentives we've done have been targeted both at the teachers and at the students. And the teachers, it turns out, when we started trying to call people, all of our numbers were wrong because we have a data sharing agreement with the school system, but we get the phone numbers that are in the roster at the beginning of the academic year, and people's phone numbers change a lot. So we never had the right phone numbers, but teachers typically do. So it was, but asking teachers to do one more thing during the school day can be a lot given they're spread very thin amongst the responsibilities that they have. So we said, can we incentivize you? Can we give you some supplies for your classroom? And can you please call parents? And that's worked really well as well. So I mean, again, with all these things you're going to hear this afternoon, there are recurring themes, but there's also sort of the concept that there's no solution that works perfectly everywhere. And I think anything that you're doing with community engaged projects, you have to learn from your community as to what works best for them. And they will tell you, we have schools that say, don't even bother with email. We have such a low population of parents that do email. Then we go right to paper and phone. And then we have others that we have a huge response by email because that's just their habit with schools and to how they respond to things. So there's sort of, strategies to use, and you up or down regulate them based on what you know about that particular environment.
So I was lucky enough to enroll my oldest daughter in the Rochester City School District and go downtown and fill out that application process and get that package from them. And it is overwhelming. And so I think you're right. You have to look at the system and you have to target the population and do what's best. You really have to go and talk to that group and figure out what's best for that particular group. All right. So we have one more resident presentation. And that is going to be, where am I here? Eileen, they're still making you present? She's got a job. She shouldn't have to present at this point anymore. Eileen's a senior resident at FEI, the Philadelphia native, entered medical school at Jefferson Medical College, laser focused on becoming an ophthalmologist, and her passion for vision care didn't waver. While in medical school, she published while working in research labs at Wills, New York Eye and Ear, and the NEI. She has already published or contributed to over 25 peer-reviewed manuscripts, ranging on topics from population-based health to ocular oncology. She feels fortunate to be part of the close-knit community at FEI and to have the opportunity to learn from her attendings, fellows, and co-residents. We're excited to have Eileen back, and look forward to the great things she's going to accomplish. Outside of FEI, she enjoys meditation, jogging, reading short stories, and she'll be joining Mount Si on their burgeoning comprehensive ophthalmology service, which apparently we're supplying all the residents, graduated residents for. So congratulations, Eileen.
All right. Thank you for the introduction. This is a topic very close to my heart. I was a coordinator for a pediatric vision screening program before med school, so I'm excited to talk about this. I'm going to present kind of a complement to Kayla and Brittany's presentations on school vision screening, and I'll be presenting on pediatric non-school-based vision screening.
All right, so Dr. Ramchandran and Dr. Giringer already sort of discussed Mobilize, so I'll talk about Mobilize at our centers. Our centers are Rochester recreation centers. Aim is to promote healthy living, education, creativity, self-discovery, and positive relationships, considered kind of safe spaces for kids and families. And there are 11 R centers across Rochester considered in urban settings, okay? And so during summer 2024, Pediatric Mobile Eyes went to 5 screening sites, all R centers listed here. And these are, the descriptive statistics for that. So 123 children were screened across the 5 sites in summer 2024. Average age was 9 years. The age range was 4 to 16. 46% female and 4% had glasses prior to screening. And 28 out of the 123 children, which is 23%, failed the vision screening. Failure was classified as near or distance visual acuity worse than 20/30, and all 28 children failed on the basis of distance visual acuity. The near visual acuity actually had a 100% pass rate. All kids had 20/30 or better, and 93% of kids correctly identified 5 out of 5 color plates on Isahara testing. So of the 28 children who failed the vision screening, 27 or 96% needed glasses, and 1, which is 4%, had possible congenital cataract. This was visual acuity of light perception in the affected eye. I don't have the data, for this child because, of course, of some of the privacy and data restrictions that I think is just inherent in this topic. So I think this was sort of talked about a little, so I'll just, repeat it just so everyone's on the same page. So what does New York State legislation say? Essentially, education law requires that students in public schools receive vision screening as part of the school health services provided by each district. This is K1, 2, 3, and then it's nearly every odd year, except 8 and 9 are both not screening years. So you kind of think, so who doesn't get screening? So anyone below school age, so anyone who, usually it would be around 4 or 5 years of age, that's when people start kindergarten, so prior to that, children in the grades that aren't kind of screening years as listed here, and then any kid in a private or a home school also would not receive screening. And so that sort of gives rise to non-school based vision screenings, because as you can imagine, there's a lot of kids missed there. And even when you think about kind of what Kayla was saying about screening at Albion and how 78% of the kids there were screened, but 22% were absent that day, and that is a trend kind of we increasingly see, and we need to get those kids screened. So these are some of the methods we use to do that. So I'll start off with primary care-based screening. So there's no state requirement for vision screening in pediatric offices. As you can imagine, they're time-consuming, especially sort of using a traditional chart like what Dr. Collins was saying. And there can be lack of cooperation with that. But of course, there's also these time constraints of everything else that has to be done in a pediatric visit, from vaccination to milestones and everything in between. So there's not a ton of time for vision screening. It's important to note that these can be reimbursed, actually, vision screening in a primary care office. CPT codes for visual acuity screening using an eye chart, and CPT codes for vision screening using a photo screening device are listed here. So these are some of the photo screening methods we were talking about. Most of them work fairly similarly, where a child kind of looks into the camera of the photo screening device, and the device kind of takes a picture sort of their eyes and analyzes that. A couple of the devices, like the spot screener, makes a noise to try to get a kid's attention, that it's like a little chirp noise. And so a few of them have kind of things like that incorporated. And then Go Check Kids is actually sort of links to a mobile application, which can also be used. And so the sensitivity of photo screeners is about 85% or greater. Specificity is 70 to 90%, but it depends on the age of the child and the device used. And, also kind of, it depends on how kind of trained the the personnel kind of using the screener is. So this is also, there's a high sensitivity in children with developmental delay or autism spectrum disorder. High family satisfaction and cost effectiveness is noted in photo screeners and primary care-based settings. And so now we'll move on to home-based vision screenings. And you can imagine, you know, using kind of paper charts, or whether usually it's not a photo screener, rather it's like an instrument-based screening, so an app or something. Some of the apps here I had mentioned, Go Check Kids, Peak Acuity, and EyeSight Pro are others. And you can imagine that home-based screening, the benefits are, you know, that it's completely remote. A few papers kind of were published on the topic around the time of the COVID pandemic. And also there's an accessibility associated with home-based screening. But, you know, disadvantages, you have very variable diagnostic accuracy and reliability, partially on the basis of what I was saying about how good is the personnel, how good is the parent in this case at actually, you know, doing the screening. And also a parent has to be engaged and they have to actually want to do the screening, which also, you know, can be an issue. So community vision screening. So this is, you know, going back to the pediatric mobile eyes screening. That's what this is, a community vision screening. So community vision screening programs are made by a couple different types of groups. One, you see academic institutions like Mobilize. You also can see them by nonprofit organizations. Vision to Learn is one. They started in LA and they do screenings in 325 cities nationwide now. And then some of the more common nonprofits that we, you know, in the eye care space have certainly heard of, like Prevent Blindness and Lions Club, also have components of their organizations that do pediatric vision screening. And then you actually see even companies doing community vision screening. For example, VSP Vision established and funded VSP Vision Eyes of Hope, which does pediatric vision screening. So the challenges, you can imagine funding source probably being the biggest of those challenges. I mean, going back to this slide, I mean, this isn't necessarily something that a company, you know, has to deal with, but academic institutions, nonprofits, there's obviously so many components of this. You know, there are so many components of vision screening. So you can imagine how many people are needed to do a station for distance, near, color, writing down all of the data, and then just like coordinating everyone on the day of. That's at least 5 people, and that's just during the screening itself. Then there's issues of parental consent and data privacy. You know, we talked a little about that in, you know, school-based screenings. So they're in the setting of non-school-based screenings, parental consent is needed for everyone. And with respect to data privacy, sometimes with school-based screening, depending on how it is, sometimes the school is the one who maintains the data, and then you get de-identified data. That's all the institution receives. It sort of depends. But you can imagine that with community vision screening, sort of the data privacy issues that can come up. So some of the pearls of program implementation are partnerships and the importance of them in community vision screening. So like academic institutions partnering with summer programs and other community initiatives like YMCA or Boys and Girls Club. Mobilize is like partially funded by Mother Cabrini Foundation and the Platt Vision Access Fund. Prevent Blindness actually has a program with Zenni Optical. And so in terms of future directions, you know, I just sort of mentioned the partnerships. I would say the second, advocacy for mandatory pediatric vision screening in all states. Dr. Ramchandran had mentioned how 10 states have no mandated vision screening. And then in the 40 states that do have mandated vision screening, guidelines differ widely from state to state. I think future directions also include funding for photo screening in pediatricians' offices and for vision screening teams. And the last is incorporation of a social worker into vision screening teams, so they can help families overcome barriers to attending a child's appointment and establishing care. And I think there's also a role with social workers in terms of, you know, obtaining consents so kids can get glasses and even get referred to some of these academic institutions. These are my references. And then here are some discussion questions, some more homework, Dr. Collins. So what are the most successful models of non-school-based community outreach for vision screening, and what lessons have been learned from their implementation? What are the ethical considerations in community vision screening, particularly regarding consent, data privacy, and equity in care access?
Great job, Eileen. Eileen, you and I met years ago, I think at APOS in maybe DC.
Yeah, I remember.
I'm sad you're not going to become a pediatric ophthalmologist. I'm a little disappointed. I don't mean to guilt you
No.
publicly. But I literally have cited some of your papers in my talk, so you're famous to me. You can come back. You can come back to the dark side. So, what are the most successful models of non-school-based community outreach for vision screening? I think these partnerships that you've talked about, Vision to Learn, when they partner with us in the schools during the year, and in the summer they go to YMCA, they go to boys clubs, girls clubs, things like that. I think that seems to be a good place. The kind of goal with vision screening, as you pointed out, there are many steps to it depending on how many components of a vision screening, and if you're doing everything on paper like we still tend to do in Baltimore, or you have things more electronically put together, it just takes some people. So you want a lot of kids. So if you're going to do this, you're not doing this for like 5 kids. So I think, trying to find the summer programs, the library programs, I think that's really helpful. Go Check Kids is one of the mobile-based apps that's kind of nice in that it actually integrates into the electronic medical record. Specifically, I know it integrates into Epic, which is really nice. So if it's done somewhere, it reports it right into Epic, which I think they use as a selling point when they market themselves to community practices when they're doing vision screenings. In terms of sort of the ethical considerations in community vision screening, I love that you're asking me an ethics question. One of the things that I feel is a lot of the times when we're doing the community vision screening, often we have parents there, so it's actually easier to get consent in some of my experiences with it. Now, that's probably different when you have like a summer program and kids are somewhere all day. But my experience is when you can get the consent from the parent, then you're getting the permission to do the screening, you're getting the permission to have, ideally the data for whatever purpose you need it, if you then want to have social worker call to connect them with care in the community.
Yeah, thank you.
Thank you.
All right, it's my pleasure to introduce Dr. Meghan Collins today from the Wilmer Eye Institute. Before I give the formal introduction, we went out and had a nice dinner last night and had a great conversation. It was very enjoyable, and I was trying to show off Raji's program and tell her how great we were here. And I said, "Oh, we screened 2,000 kids last year, and this year we did 3,500. We're still having problems with consents and things, but how's your program doing?" "Oh, we screened 55,000 kids last year and with a 90% follow-up rate." I was like, okay, forget it. I had no idea. I knew you guys were good, but those numbers are staggering to me. So we really appreciate that work and looking forward to learning from you here today. So Meghan's the Alan and Claire Jensen Professor of Ophthalmology at the Wilmer Eye Institute, Johns Hopkins, where she specializes in pediatric ophthalmology and adult strabismus. She also has faculty appointments at the Bloomberg School of Public Health, Johns Hopkins Berman Institute of Bioethics, and Johns Hopkins School of Education. She attended the University of Notre Dame for her undergraduate studies in biology, philosophy, and history. And she received her medical degree from the University of Chicago, where she also completed a fellowship in clinical medical ethics at the McLean Center. She completed her ophthalmology residency at the University of Chicago, serving as chief resident during her final year, followed by a pediatric ophthalmology and adult strabismus fellowship at Sick Kids Toronto. She received her master's in public health from the Johns Hopkins University Bloomberg School of Public Health. Her research interests include health disparities in pediatric eye care, school-based vision programs, the impact of vision on academic outcomes, and public health ethics. Since 2016, she has led Vision for Baltimore, a research and service delivery collaboration with Baltimore City Public Schools and the Baltimore City Health Department, where they have led the nation in systematic vision screening of school-aged children. At present, they screen more than 50,000 children per year and have a more than 90% follow-up rate for screen failures. Dr. Collins is widely recognized for her work in school-based vision care, having published extensively in this area over the past decade. She has also served on advisory panels for the National Eye Institute and the WHO, including a recent appointment to the WHO SPECS Initiative, Scientific and Technical Advisory Group. She is actively involved with the AAO and APOS, and she's also involved in advocacy work to promote evidence-based vision screening standards at the state and national level. She also loves teaching and mentoring pre- and postdoctoral trainees and is passionate about helping to strengthen the pipeline of individuals pursuing careers in pediatric ophthalmology. There's a lot more we could say about her, but we really appreciate that you're here. And while she presents Building Strong Systems for Pediatric Eye Care Delivery, the Role of Community in Schools. Welcome.
Yes. We'll see. Can you guys see the screen? There. Can everybody see? I feel like you can probably see the screen and not me. I feel very short behind this. So, hello everybody. Thank you. Hold on a second. This is embarrassing. I don't know if anybody knows my boss, Michael Repka, who's president of the American Academy of. Don't do that.
Here we go.
Most embarrassing start of a talk ever. But he's about 6 feet tall and I am about 5'2". And we switch off some weeks in doing ROP exams in the NICU. And I come and the nurses are like, Dr. Repka never needs to have the bed lowered. So, welcome everybody. Thank you so much for inviting me to be here. Thank you all for still being awake at 4:15 on a Friday afternoon. I'm just so amazed by your department and your commitment to population health and the energy of the residents. I want more to go into pediatric ophthalmology, but that's what I'm hoping to accomplish in the next 45 minutes. You guys can hear me okay? Perfect. Okay. And here's some relationships to disclose. And I do want to acknowledge some of the funders that have been involved in some of the work I'm going to talk about today. And I also want to acknowledge a team. There's a huge team here. So very nice to talk about how many vision screenings and what our consent rate is, but this is by no means just me. We have, and there's many more that have been involved in the program over the years. I ran out of room on the slide to include, but we just have an incredible team of individuals similar to your group here who are really passionate about what we can do to improve eye care for kids in Baltimore. So 3 main objectives of today's conversation. One, I'm going to talk a little bit about vision screening practices for school-age children in the United States. I will try to glaze over the areas that we've already talked about with our prior speakers, talk about school-based vision programs, and summarize some of the lessons we've learned so far. Some of you may be aware of this. Several years ago, the American Academy of Ophthalmology's task force on disparities in eye care put out an entire issue of ophthalmology specifically talking about disparities in eye care and eye health. And for me, this was, I think, my favorite issue of ophthalmology ever, October 2022, because there was this collective recognition by the ophthalmology community about disparities and how disparities impacted access and health literacy and diversity of the workforce, and what we as a community really needed to do about this. And this one quote from one of the articles I'm always sort of struck by about what we need to do to improve access to care, as well as increase diversity in our workforce, enhance eye care and healthcare literacy, and all while leveraging data. And I'm going to talk several points today about data, and it seems like you are also very data-driven here, because the important thing is not only are we trying to implement a program, but at the same time,
We're trying to collect data, we're trying to measure where we are, and we're trying to continuously improve. When we think about disparities in eye care, I think it's also important to illustrate social determinants of health. This is a slide taken from Kaiser Family Foundation, but really sort of recognizing where you live, what you eat, your home environment, your neighborhood, your economic stability, your school system, all are going to impact your eye health. And there's been much more interest and attention in disparities in pediatric eye health probably since the pandemic than there had ever been before. And part of the reason I think that happened is there was such a disruption into social structures and social safety nets for kids when the pandemic happened that people suddenly became aware of, well, there are a lot of services that happen when kids are in schools, that when schools are closed, they don't get food, they don't have that shelter during the day when they're in unstable housing environments, they're not getting access to their vision screenings. So there's been much more published by our pediatric ophthalmology in the last 5 years, looking at some of these challenges, whether it's race, ethnicity, socioeconomic status, is it impacting access to screening? Is it impacting access to eye exams? Is it even impacting outcomes from amblyopia? So we all probably are familiar with amblyopia at this point in time, and of course the devastating permanent impacts it can have on vision. And this is from Michael Repka looking at the Academy's IRIS registry data, just thinking about the dramatic impact that whether or not you're from, you have Medicaid, lower socioeconomic status, Black children had much poorer amblyopia outcomes. And amblyopia from I think a pediatric ophthalmology perspective is one of the things that we can diagnose and treat. But again, some of these barriers exist. And when we think about kids, the other thing to think about is it's not only their vision, it's their vision and how it's impacting their life course, their development, their quality of life, their academic attainment, their future educational attainment. And it's really thinking about this intersection between education and health. And the kind of, that's bi-directional thinking, not only, being in schools can provide opportunities for health services, but also poor health can put your education at risk. And that becomes particularly salient when we're talking about not being able to see well in the classroom. And this is also, some of you might be aware, CDC has this WISC model, whole school, whole community, whole child framework. Again, it recognizes the intersectionality of all of these different factors and how they impact child well-being and success in the classroom. HHS Healthy People 2030 has had as a priority goal achieving the highest level of health for all age groups, and it had priorities established in pediatric eye care, and this includes increased access to screenings and reduced vision loss in children and adolescents. And when we think about, you've heard a lot about vision screenings today, and you probably already know this, but I think it's always, repetition here is always helpful. What does a vision screening do versus what is an eye exam? Vision screening helps detect somebody at risk for an eye problem. It will not diagnose their cataract, it will not diagnose their refractive error, but it will tell you that there's something that looks abnormal and they need to have a comprehensive eye exam. And as you've already heard today, one of the challenges is you can have a screening, it can be abnormal, but then connecting to the care, whether it is in the primary community setting or in the school setting or somewhere else, how do we make that happen? And there's attrition, as you've heard about at every single point, whether they get the screenings in the first place, whether they follow up after the screenings, whether they get the glasses. And the other thing to think about when we think about vision screenings in kids, historically, I think we used to think about screening for amblyopia risk factors. So we really wanted to target those pre-literate kids, 3 to 6, because those are the ones that we could intervene on amblyopia, so we wanted to detect. I think our thinking on that has shifted over time because we recognize that's really important to do. But in addition to that, in the school age population, your younger kids are also still at risk for amblyopia, but then you have this huge number of kids with kind of a growing prevalence of uncorrected refractive error. And of course, you already heard today about the burgeoning myopia epidemic that we're seeing in terms of the number of kids that become myopic during their school age years. You've heard today about vision screening and vision screening requirements by state. And this, I'm going to harp on again, as we've talked about already, there's no national policy, there are no national guidelines for vision screening. So it's very much state by state. You live in New York, it's different than if you live in Maryland or if you live in Wisconsin. In New York, I would say, is one of the better states in the fact that they have biannual vision screenings. Maryland, it's grade of first entry, first grade, and eighth grade. So you have this huge gap of, second through seventh grade where kids are not getting access to vision screening. And then you have some states here that actually have no vision screening requirements at all. They may do things district to district, but they have no state mandate. And it's not only sort of whether you have vision screenings that exist, it's what are they? Is it distance? Is it near? Is it color? Is it stereopsis? Is it instrument-based screening or some combination thereof? And part of this variation often leaves parents, teachers, nurses, primary care providers at a loss of what are they supposed to be doing? What's the best practice? And APOS, Academy, AAP, they all actually have guidelines on this, but they don't certainly match what the state guidelines are. So what happens after a vision screening? If you have a vision screening, whether it's in the school or the community setting, if you are referred, you're supposed to, the expectation is that you see an eye doctor in the community. And then if you're found to have something wrong with your eyes, with kids, honestly, by and large, it's refractive error. We definitely see some amblyopia and strabismus, some more complicated posterior segment pathology at times, but for the most part, most kids simply have uncorrected refractive error. But again, we've talked about attrition at every level, whether they get the screening in the first place. This has become a huge challenge post-pandemic because of chronic absenteeism. So you'll come to the schools to screen, as we heard about from our residents today, and the students won't even be there. And after the screening, sort of how do we connect them into care in the community? How do we get them the glasses? Do they have insurance that covers glasses, covers replacement glasses? And then how do we get them to wear them consistently? And in our US population, we estimate roughly 20 to 25% of school-age children need glasses. When we started our work in Baltimore, it was only 5% of kids who needed glasses were actually wearing them. So you see this huge disconnect depending on what community you're in. And then just kind of following up more on disparities in vision screening access and follow-up. One sort of big picture, we find that communities that have higher risk factors, there's an increased need for vision screenings in the first place, but there's decreased access to the vision screenings and decreased access to follow-up. And we analyzed some of the data from the National Survey of Children's Health, the 21 data, which was actually the first year the survey actually asked about vision screenings and eye exams. And one of the things that we reported on were the factors associated with the lower odds of actually getting vision screening in the first place. And the big takeaways were if you did not have a primary care provider, if you did not have any insurance, if your parent education level was high school or less, or you have a lower household income, all of those were factors that impacted your likelihood of not receiving a vision screening. So in general, children from disadvantaged backgrounds were less likely to get vision screenings. They were also less likely to get eye exams. And going back to this task force of the American Academy of Ophthalmology, they called on all of these ideas that you'll see up here about how do we improve access to care. And this was, I think, the first time that I've ever seen the Academy come out with a strong statement about schools and the role of schools in improving access for kids, not only through doing school-based vision programs, but also improving school-based vision screenings. Some of the other things that we'll probably have a chance to touch on briefly are community health centers, also sometimes referred to FQHCs, and teleophthalmology. And our story in Baltimore starts actually a few years before I even came to Baltimore, where one of our local foundations that does a lot of work in education and health brought to sort of a city convening. Why do we have so many kids in our city that are not reading proficient? To sort of have, one of the greatest predictors of success in school is your reading proficiency by the end of third grade. And we had so many kids that were not reading grade level. And the question is, how many of those kids who weren't reading grade level had also failed a vision screening? And of those who had failed a vision screening, how many had not gotten access to an eye doctor? And it turns out that it was a lot. And it wasn't sort of, making the direct causation that if you if you couldn't read, it was simply because you had a vision problem, but it was asking, do we have some of these kids who are failing in school that maybe they simply can't see? And so the question came up, well, if there are some, then can we think about different solutions that would involve schools? And you'll see some of the work here. I've tried to highlight of the great work you guys are doing out of Flaum with the Pediatric Mobile Eyes Clinic, and your star resident, Eileen, I think was also involved in the Philly Give Kids Sight Day, which is, I think, a very cool program run out of Philly that brought the kids into the community, partnered with the school district, right? Am I right, Eileen? And then, of course, our program in Baltimore, which I'll start talking a little bit more about. So this is meant intentionally to be blurry. This is sort of, you know, you mimic a phoropter. How blurry is this, number 1 or number 2? And you know, imagine, I always challenge people sometimes during these conversations, if you're wearing glasses, take them off and see what it would be like to look at this. It probably is going to be blurry for you. And so, you know, there's started to be an accumulation of data about the academic consequences of vision impairment for kids. And these become, I think, even more important when we think about kids who are already not achieving and in schools, districts where they're not at proficiency for math or for reading. And of course, we had done work out of Baltimore. Alex Levin, who's now here with you, and Eileen had done work in Philadelphia. So it started to be sort of more data coming out about this correlation between vision and academics. And this was, you know, some of this was what inspired us to build a program in our city. You've heard a lot about the programs that you have in both your rural and more urban areas. Baltimore, for those of you who may not have been there, is an entirely urban school district. We have about 140 elementary and middle schools. That population of students is about 60,000 across those schools. And all of our students we have eligible for free and reduced meals because the metrics of poverty are so high across all of the schools that we just provide them all with free meals. So, so it's a very impoverished area. You don't find a ton of school districts like that every single school is so high poverty, but we happen to be one of them. And we recognized if we should do something, we should do it for all the kids across the city. And we launched a program. And I think the key thing here is that it wasn't launched by one partner. It was launched by all the partners across the city. So our health department, our city school system, our anchor institution, Johns Hopkins, and then some national partners, including Vision to Learn. You've heard about them a little bit today. They're a national nonprofit optometric provider that supports mobile vision units. And then Warby Parker, one of their co-founders is an alum of Hopkins, and they have been very passionate about social philanthropy, and they have a buy a pair, give a pair program. So every time they buy a pair, they give a pair away for free. And they've done a lot of work globally, but actually with our program and some work in New York, they started doing a lot of work in the US. And one of the key components of our program is that we bring everything to school. We've heard about all of these like points of drop off. If you have to go somewhere for a screening, you have to go somewhere different for an eye exam. If you have to go somewhere different for glasses, you lose kids. So we bring everything to schools, which until the pandemic was a brilliant idea. During the pandemic was a little bit more challenging, but we have all of our partners participate in this. Our screenings are done by the health department. We do distance acuity and we do spot vision screening. Our eye exams, which are non-dilated, are done by Vision to Learn. And then if kids need glasses, they're actually able to pick them out the same day of their eye exam. And Warby gives us tons of colorful frames that kids like. And that's a big deal for kids. If they're going to wear glasses, they have to like them. They have to fit them. They have to feel that they're, you know, that they're going to be able to see better, but they're also going to be accepted among their peers. In addition to that, what we've recognized is that sort of what's the stickiness to make a program really work? It's having these key components, but it's also integrating yourself into the school system, building the relationships, and working through the operational logistics. And I think all of you who are doing this work sort of appreciate how important these components are, which is, you know, making sure that you come to schools and you have a list of all the kids that you need to screen, and that you have a place to screen them, and you have somebody to write down all of the documentation as to the outcomes, and you have somebody preparing the information that's going to go home, and you have somebody sharing that information with the school nurse. It's all of these communication components that are really essential to making sure the program gets executed the way that you intended. And we actually have an entire team of school vision advocates that are from Johns Hopkins School of Education that have ongoing relationships with our schools. We're in the 9th year of our program, so they have literally been working in these schools for almost a decade. And we actually have had amazing sort of stay power of these SVAs. We have 3 of our SVAs have been there since the first day, our school vision advocates, which is pretty phenomenal that they can, and so they're well known in the city at this point in time. So to date, we have screened over 130,000 students in the past 9 years and completed over 22,000 eye exams and provided over 18,000 students glasses. And we're largely regarded at this point in time as sort of one of the most successful city, public, private, school-based partnerships in the city. Again, because I think we all came into this together, and we've had our growing pains over time as we have the same challenges that all of you have had here. As we've been doing this program and we've sort of had this success and some of those great metrics, we also thought it was so important to do research and to look at the evidence base as to what are we finding? How many kids have refractive error? How many kids have non-refractive error? What's the academic improvement? And that's part of, I think we think in addition to providing a service, we want to be able to build an evidence base that will help other programs and help develop best standards. So one of the first questions that we asked in our research was how many kids in the city were failing. And this is, I sort of commented on this before, it's pretty similar to what you're seeing here. We had about 1/3 of our kids were failing when we started the program. I have this broken down by grade above, and what you'll see is it actually increases as you get to the higher grades. I think a lot of that is probably due to myopia. But the other notable thing is, so the difference between the blue and the yellow bars here is that the blue bars are the state mandated grades, the yellow bars are the non-mandated grades, and it's probably obvious to all of you that there's not much difference. There's no statistically significant difference between those, which is suggesting that whether you're in a grade that the state mandates or not, your risk of failing a vision screening is high, which is why we as a program made the decision we're going to screen every single grade. We're not just going to go with the state mandated grades because we recognize there's such a high need. Now, over time, that will probably become a question of the program because we've been doing this for so long. Should we decrease the frequency? But at this point in time, we're still doing it every year. The second question was what types of eye exam findings were we seeing, and specifically what types of refractive error. Now, this slide it's a little bit busy, but it breaks down your distribution of refractive error, and you'll see the definitions at the top in terms of how we're defining myopia, hyperopia, stigmatism. I do want to point out we're using epidemiologic definitions here. This is not our prescribing criteria. This is if you wanted to look at an entire population of kids and get an understanding of how many have myopia, how many have hyperopia, how many have anisometropia. This is what we did here. And again, one of the things that you see is your myopia increases as kids get older, your hyperopia decreases, your astigmatism and aniso stay relatively stable. We then wanted to look at if we give kids glasses, how much better do we get with their vision? And this is organized by looking at the better eye and the worse eye. And one of the striking things is even in the better eye, you're getting some substantial improvement in vision in kids. And it's amazing. I think one of your case studies was about the child in the hospital who had poor vision and got glasses and was able to see better. The number of kids that we've seen that sort of have -10 myopia, and this is their first pair of glasses, it's sort of shocking to see, but at the same time really rewarding because you're like, this is a kid we can really make a big difference for. So the question that our education stakeholders and our policymakers really pushed us on, and I think in a really important way, was what type of difference does this make for learning? And when you're thinking about partnerships like this that are going across education and public health and medicine, you have to think about the investments people are making of time and resources and what they will ultimately see as value add, return on investment, and reasons to support you in growth and scaling. And for us, one of the things was we have a lot of kids academically struggling in Baltimore. Are we making a difference for them? And we conducted a randomized controlled trial over 3 years from 2016 to 2019 and looked at kids across 3 cohorts, kids who got screenings and eye exams in the first year versus the second year versus the third year, and looked at both the 1 and 2 year impact of glasses on standardized tests in reading. It's called English language arts is the equivalent of reading, and math. And our results were pretty profound, particularly actually in English language arts. We did not have as much success with math. Our education colleagues have a lot of theories about that, mostly in terms of sort of the cognitive processing it takes for math and the cumulative knowledge. Simply a pair of glasses may not be enough to change the needle there. But we saw large gains for girls, kids who were in special education, and students who were in the lowest quartile of their class. So this is your bottom 25% of students were the ones that actually had the most gain when they got a pair of glasses. And we looked at gains in terms of sort of how did it compare with other educational interventions. Again, this gets back to when you're trying to build and expand these programs, who's your stakeholder and what do they want to hear about? I can tell you policymakers are not excited when I tell them we found like on average 3 diopters of myopia. They want to know about your learning gain equivalents. And we looked, and you have to quantify it in terms of other things that they are hearing about and see in educational interventions, and tutoring is one of the most powerful ones that you hear more and more about these days, particularly post-pandemic. So our kids who were envisioned for Baltimore, your full sample of kids, the intervention was more effective than common educational interventions like laptops, extended school days, being in charter schools. But your kids who were in the lowest quartile at baseline, kids in special education, actually had a more robust effect from glasses than they would have had from tutoring, either in small group or one-on-one. And again, this is not to say, don't do those other things, just give kids glasses. It's really just to show you how transformative a pair of glasses can be for a kid who needs them. So kind of wrapping up our vision for Baltimore portion of the program, we have a huge failure rate in our city. It's 1/3 of our kids were failing. And we were able to develop a program that provided all of these kids who were failing access to eye exams and then access to glasses. I think I heard some people talking during the break, like if we could do everything on the same day, could we do screenings? Could we do eye exams? Could we do glasses? I think we'd have even less attrition than we have in any of these programs. And that certainly is kind of one of the avenues moving forward. We are also at the same time as doing program implementation, doing research on impact and looking at not only improvement in vision, but also improvement in learning. So school-based models like this can work, and I think they can be incredibly successful, particularly when you're looking at disadvantaged communities that already have so many educational and health disparities, and thinking about the interrelatedness of addressing a health disparity may improve education, and addressing an educational disparity may improve health. So how do we keep this going in perpetuity is really sort of the next area that we have been thinking about. And, we have struggled in the exact same way as all of you with regard to consent. And how do you get kids to participate in the first place? So how do my sort of list of what are the challenges of school-based vision programs, they're right up here. So how do you get kids to participate? How do you get kids to wear their glasses regularly and get them replaced if they're broken? How do you make these cost effective? How do you develop the community connections and follow up for the kids that have something more complex? How do you deal with pandemics? Because I will tell you, very disruptive to school-based services. And I don't want to say we're going to have another pandemic because that's a bad thing to say on a Friday afternoon, but it's possible. And how do you continue to kind of build and iterate on evidence-based models of care? I'm going to talk a little bit about the 4 areas that are bolded here. I will leave pandemics alone. So as I was mentioning during our conversation earlier, we did focus groups. At this point in time, we had been working in both Chicago and Baltimore public schools, and we went to parents, we went to grandparents, we went to school staff and said, why do you think kids are participating or not participating in this program? And the major issues and themes that were identified is what program are you talking about? I'm ineligible. Glasses will make my eyes worse. I forgot to mention that before, but there is sort of this stigma sometimes, or this fear that if I wear glasses, it will make my vision worse. They didn't trust the program, or they had an existing eye care provider. We're okay if they have an existing eye care provider. That's actually great. That's success. But these other four are the ones that we're often dealing with. And when I was doing some of these interviews in Chicago, it was really interesting because a lot of the students we worked with were taken care of by grandparents. And grandparents, apparently, when they had been in school in Chicago and needed glasses through programs like these, every single frame looked the same. They were the Buddy Holly frames, and they got mocked for it. And they actually didn't want their kids to participate in the program because they remembered being mocked for wearing glasses. And so telling them and even showing them the selection of different colors, sizes, frames was really a game changer for them. So sometimes it's simple things in terms of why people are not participating that improved health literacy and communication can make a big difference. We also, as I alluded to, have thought a lot about how do we get consent. And it is a continued struggle. These are some of our school vision advocates who they've done the work. They've been the ones on the ground building the relationships and doing this. But as I mentioned, we've got universal consent. So we have consent that goes out before we do vision screenings, and we have targeted consent in phases after the vision screenings. The targeted, we do electronic, we do telephone and paper. And we use our staff plus school staff plus med student volunteers. Anybody who wants to help us with this, we say, come on and help us. And this is some data we had just presented at APOS a couple weeks ago. I don't have a pointer here, but as of last year, our response rate was about 86%. What you'll see across the slide is looking at the distribution of where are we getting the responses from. So as you can see, we're getting about 15% of our responses from Universal. Universal is only electronic. And then you start to see sort of this growth over time. The targeted email, you get a bump, not a huge bump. Paper, you get a bump. You get your biggest bump from phone. So some of the operational considerations for this is it used to be that we finished screenings, we'd send paper consents out, and it would take weeks to get everything back, and we couldn't even schedule our providers to come to school because we didn't have enough consents ready for kids for them to examine. Now, because we already have a whole bunch of kids from Universal, we're ready to start on day one, that they can come to schools. And then what happens is there's a little bit of a snowball effect of parents see the van at schools, and it's a prompt for them. It's a reminder like, oh yeah, I forgot to put that form in. And that's really helpful in terms of us getting more. The only thing I'm hesitant about with this data here is if you look at this and you were being very utilitarian, you would say, what's the best way to do this? It would be phone, right? But what we didn't measure here is the resources it takes to do phone versus electronic and paper. And the magnitude of order is just so much more that I still think is worth starting with the other ones. And I think I mentioned we're all opt-in for our exams. The other thing is looking about the costs of the programs. This is also some work that we've presented at APOS before. So how much does our program cost? And this is a breakdown both by vision screenings and eye exams and components. This is a 3-year cost, just so you know, and this is our first 3 years of the program. It was about $2 million to operate. I should mention all of this has to do with the vision screenings, the eye exams, and our estimated cost for the glasses. It does not include the school vision advocates, the support that comes from Hopkins, because that's sort of independent from the program. But what you'll see here is roughly you're spending about half of the money on vision screenings and half of the money on eye exams. And looking at a breakdown a few different ways, among the population that we had screened during those first few years, the cost of vision screening distributed over those kids is about $17, $18. So it's remarkably low. The cost of eye exam for a child who got an eye exam and glasses is about $100. Now, in truth, this has gone up a little bit over time because of the because of the pandemic and infection control standards changed. We can't have as many kids in close proximity to each other as we used to, so the number of kids we can see per day has dropped. But still, I think our cost of exams is about $150 right now. And here it was $105. Now, in contrast, think about how much it costs to educate a child in Baltimore City Public Schools. So our 2023 data, it's about $22,500. So it really is a pittance to do an eye exam on a kid who needs it. And again, can be pretty transformative in their educational trajectory. The last part that we talked about this at dinner a little bit last night too, I'm really interested in is what happens beyond school-based vision programs. And I think the data that your resident showed today was very interesting about how many kids are referred for something more. So school-based vision programs are wonderful and they're a great place to access kids where they are during the school day and provide services that they historically have not otherwise been receiving. But you will have kids with amblyopia, you will have kids with strabismus, you will have a lot more myopes than you used to have, and there are many more community-based options for myopia control. We have to start thinking about how do we connect these kids into the system that has been really hard to get into long-term. How do we do that better than what we're doing right now? And to answer that question, we really sort of looked backwards and forwards. We looked at our program in Baltimore as well as other school-based vision programs to look at how many were actually referring kids, how many were referring kids into the community, how many had published guidelines about it, and how many were tracking it. So it turns out, similar to vision screening guidelines, it was all over the board, and people didn't really necessarily always have routine guidelines as to how they were referring kids, but most programs' referral rate was about 5%. Referral adherence, meaning I sent you to see Dr. Geringer, or did you actually see Dr. Geringer? It wasn't routinely tracked. We've had the same problem in Baltimore because it starts to get into data privacy issues of HIPAA and FERPA, and we referred you off, and did you actually get connected or not? But this remains a challenge. And we did a partnership over the last few years with Helen Keller International. They're a big global nonprofit that does work both in the US and overseas in vision care for kids. And one of the things that we looked at with their data set, their program very similar to ours, except they serve older kids than we do. But they do sort of the same thing. They do vision screenings, they do an eye exam, they give glasses, they give community referrals. Their failure rates are pretty similar to ours. Their prescribing rates are pretty similar to ours. Then we looked at how many kids were being referred to the community. And it turns out it's actually higher than ours. It was about 15%, and it was 1 in 7. One of the really notable things, though, is if you look at this breakdown by age, it's a lot of young kids. So you start to think about who are the kids seen in school-based programs that are being referred the largest amount, and are there other things, are those the best kids to serve in a school-based program? Do we need childcare specialists or somebody to help make those exams in the 5 to less than 10-year-olds easier? I'd say a 5-year-old is much harder to examine even in the clinic setting than a 10-year-old. So just thinking about some of those things when you're building these programs and operational considerations. We did a survey. Am I okay on time? Okay. We also did a survey looking at vision programs in the US, and Rajiv and I were just talking about this. One of the things I would love is if there were a registry, there were a central registry, so we could find out how many school-based vision programs are there in the US, what are they doing, what are their practices, and then disseminate knowledge that I think all of us have collectively gotten, like, hey, we have the magic bullet for how to do consent, or we have great health literacy material and these videos that seem to resonate with families. So we did a deep dive using kind of both the peer-reviewed literature, publicly available gray literature, and then sort of phoning contacts, looking at how many school-based vision programs there were in the United States. And we found about 184 programs across 19 states and Washington, D.C. One of the things with this is most of these programs are actually operated by Vision to Learn at this point in time. So I think they're the largest, they have the largest portion of this market. In terms of who are they serving the most, it's elementary schools, followed by middle and then high schools. Interestingly, because this continues to be a question of should you or shouldn't you, is only 22% of the programs were using dilating drops. And again, we do not do that in Baltimore. 73% reported a relationship with community providers. I will self-critique, which I do often. I would say problem with our survey on this question is we just had yes or no, and we don't really know the depth of that relationship. So it might mean that they just have a list that they send people, or it might mean that they have my phone number. So I think that would be one of the things that would be important in sort of knowing how effective are these community provider relationships. So looking big picture again about challenges and opportunities with school-based vision programs, one of the big challenges is just this lack of integration. So they work, but how do we integrate them back into the community? How do we establish more formal referral mechanisms, and how do we collect data on the outcomes there? And I think some of our opportunities include having standardized guidelines, thinking about best models of ongoing support. And here's where I think there's an opportunity to think about community health centers and federally qualified health centers as sort of another hub of care in the community for across the life spectrum for patients, including kids. I think there's an avenue to leverage there. And I'm gonna skip to this slide for a minute, because I just added it because we had an article come out on this in JAMA Health Forum this morning. But one of the things that we argued is if we're thinking about federally qualified health centers in this space, we really need to think about ramping up their capacity. One federally qualified health center is literally one FQHC. They're very different across the state, across the country, but there's opportunities to think about how do we increase vision screenings done on site there? How do we strengthen referral networks? How do we increase case management? How do we even build on-site or telemedicine capacity to involve optometrists and ophthalmologists more? And how do we improve education, both for the providers there, as well as the patients in the community? Because really, when it comes down to it, when you're thinking about how do we ensure this kid who is seen at a school-based vision program when they're 10 ends up having follow-up eye care, a lot of it becomes about health literacy and their knowledge and their family's knowledge and their relationship with providers. Pardon me for going back a bit. So kind of big picture, when we look across school-based vision programs, what do we know? There's a lot of models out there. There's a lot of challenges. All of you were able to elucidate some of the challenges you've seen. I've shared some of mine, but there's a huge unmet volume of kids who have needs that we can serve through these programs. And they're very effective. They're very effective at directly in schools connecting kids who failed vision screenings to care. They're very effective for kids who have refractive error, not effective for non-refractive problems. And we still, this still continues to be a challenge where we need to collect more data and we need to develop more robust mechanisms for giving kids kind of long-term eye care homes. There's a ton of opportunities to think about how do we strengthen these programs and how do we do better integration into the community. And one of the other things that I think there's an opportunity to use sort of our presence in schools for is thinking how do we improve health literacy across the schools, not only the kids that we see and give eyeglasses to. We do a lot of science vision fairs for kids for the entire grades, and it's a really fun way to have our team engage with the school, improve knowledge about, we do pig eye dissections, we do test color vision on your classmate, and it's engaging, it's hands-on, and maybe that's going to be the tipping point for some kid to think about possible healthcare careers, possible optician, optometry, ophthalmology careers. And given that we have a shortage in the workforce, particularly in pediatric ophthalmology, because they can't get more people to go into pediatric ophthalmology, I think this is really an opportunity to think about our relationship with schools through a different lens. I am done. I have time for questions. This is us dissecting, by the way. Some pig eyes. Oh, and I do have my email up there if you need it.
So I have a quick question on, so what is the lag time between getting glasses or getting the exam and getting glasses to these children?
About 2 weeks. Yeah.
I have a question while Karen's waiting. Do you know much about private foundations and the screening programs in communities? I know there's and their effectiveness. I know there's the Glazer Foundation in Tampa that has a big screening program. Like what is their effectiveness, and are there academic centers partnering with them to do the research with the kids they're screening.
I missed the first part of your question, sorry. Did I know about?
The private foundations that are doing these screenings. Like one example comes to mind is the Glazer Foundation in Tampa, and they have this big vision screening program in St. Pete's, Tampa area.
I don't know about that program in particular. One of the things that I found is most of the foundations that we have partnered with, they're more than happy to support us in doing the work. And when we're doing the work, we have the data. We've been contacted by many school districts and many existing programs that are doing things, but they're not systematically collecting their data at all. And a lot of efforts we make at times is try to help them figure out how to systematically collect their data. Because again, as you're trying to, benchmark this need and this success and changes over time, I think the more people that are collecting data and collecting in a systematic fashion, it can be helpful.
Thank you, Megan. That was an excellent talk. I have two questions. One is, with the amount of patients that were screened, what percentage of those students had any pathology in the back of the eye? Do you have any idea about that?
Pretty small percentage. So amongst our students who were screened, about 33% failed. It's dropped over time. I think we're now down to 25%. Among those kids who failed, 90+% are getting eye exams. Among those who are getting eye exams, roughly 80% need glasses. The group that's being referred for something else, and it could be posterior segment pathology, it could be strabismus, is about 7 to 10% now at this point in time. It had been smaller when we started. I think we kind of increased our number of kids that we decided to refer. We do a non-dilated fundus camera picture on every single kid, so we're able to document any posterior segment pathology. And we reported a while ago on sort of all the findings of Chicago had a huge program, and I think amongst 12,000 kids, the number of kids who had any posterior segment pathology was like less than 1%, so it's pretty small.
Okay. Because I know one of the things that optometry wants, one of the issues is that they want the screening to include dilation. And I think that's a big, one of the big things that they're advocating, which is different from our screening, which most of our students do not have dilation. Now, with the fact that we don't dilate most of the students, but we're able to take fundus photos, do we still need, if it's a part of the onboarding for the students, do we still need consent from the patients?
Yes. So we have opt-out consent for our screenings, in that a notification form just tells parents that the health department will screen. For the kids who have an abnormal screening, we send home a consent form for our eye exam. Our eye exam is a non-dilated eye exam. Some would call it a limited eye exam versus a comprehensive with dilation. We've thought and struggled a lot with this over the years of should we dilate every kid or not. I think it's untenable to have a large scale program where you dilate everybody. We published data again from the Chicago program, actually Sandy Block's program, looking at, we compared, because we had of like 12,000 kids, we had their dry and their cycloplegic retinoscopy and looked at the difference, and it's not clinically significant. The ones that it approaches clinical significance is the really young kids, which, again, I think you really have to think, I think the really young population, when you're thinking about the 4 or 5-year-olds in school-based programs, I think that's hard. I think there's a huge need and possible value in that population, but do you use the exact same protocols that you're using on the older kids? You may want to think about what your population and what your sort of bandwidth is to do dilation on those kids, or figure out how to bring them to the community. Alcon has a program now that they come to schools, but they also have a brick and mortar clinic in the communities. Chicago used to have something similar. So it's sort of this hybrid of, it's not that you have to go to Wilmer or you have to go to Flaum. You can go to you can have an exam in the school, or you can have an exam in their clinic in a school district building. And so that might be an example, a good place for the kids that need the cycloplegia.
Got a question from the chat from Peter Schwartz, who's a pediatric ophthalmologist. He's asking about referrals from spot screeners from the pediatricians as young as 6 months of age with a mildly ambulogenic refractive error. And his question is, what age do you feel is appropriate to employ such screening? So spots in pediatrician's office. And what referral criteria would you recommend the pediatrician?
Yeah, a great question, Peter. So most of the guidelines from the big professional organizations really sort of recommend like the young kids you're doing a red reflex, you're making sure they don't have a cataract, ptosis, glaucoma, anything posterior segment. But there's not, I think, a robust evidence base on the photo screeners in the 6 month to 3-year-olds. There's good data as you look to the 3 to 5-year-olds. And now we're doing some of the research looking at the 6 and above. But I too get this in my practice a lot, that I've got a 12-month-old that fails a vision screening. And inevitably the kid is looking here and the screener is here, and they all have induced astigmatism. I will say though, I have been surprised, and every once in a while it's been pretty effective in picking one up. But it's a good question in terms of sort of, what community practices are doing. I can't remember, sorry, which one of our residents was talking about the CPT codes for screening. So instrument-based screening CPT codes actually pay more than optotype-based CPT codes. So I sometimes that's part of the reason that they're actually doing instrument versus, well, you can't do optotype on a 6-month-old anyway, but.
And I've got one question too.
Sure.
Do you recall an inflection point in your process past 9 years where you said, this is happening? Like, we're getting there. I just want to know, where is that going to snowball and start happening? What happened with your program?
I think a couple things happened. One of the things is sort of recognizing, I think we went in with probably a little bit too much bravado of, oh, there's a problem and we know the answer and we're going to come in with a solution and everybody's going to be really happy. And I think it was, you go into schools and you're like, I'm going to save all your children's vision. And they said, yes, we're trying to get our kids to come to school. We're trying to get them in the classroom. We're trying to get them fed. They have other things. So I think, working in partnership and recognizing the sort of complexities of schools. Throughout my training, I had never been in, and I went to parochial schools my entire life. I actually had never been in like a public elementary or middle school until I started working on this project. And I think anybody working in this space should actually spend some time in schools because it opens your eyes so quickly to all of the challenges that they're dealing with. I think you guys are doing all of the right things. You're doing all of the relationship building, and it feels glacial at times. It feels like you're investing all of this time and effort and things are not moving as quickly as you want them to be. I don't have like prognostication as to the specific tipping point, but I can't say that there's anything that you're doing that I'd say, oh, you should be doing this too. I think you're doing all the right things.
Megan, thank you so much. That was absolutely wonderful. We have a little token to commemorate your lecture as visiting professor of the Flaum Eye Institute. Congratulations, and thank you for the lessons today and the education. It's really appreciated, and it'll help us move our program forward.
Thank you very much.